So, hello, ma'am. How are you?
Hello, Jigar. I am all good. How are you doing?
Yes, I am also good. So,
Okay.
ma'am, you are most welcome on my platform and very, very thank you to join me. And
It is
I'm
my
so
Actually, it is my pleasure that seeing you at such a good platform, and then you are also taking such initiatives for having such faculties on the platform and the confidence which is required. I can actually see that in on your face. So that is definitely my pleasure. Yes,
thank you,
please.
ma'am. Thank you. Yes, I am so excited for this conversation and I hope you too.
Yes,
So,
and even the weather has also made it more exciting.
yeah. So, today we are going to discuss on the topic of very, very prevalent disease in our India, that is none other but osteoarthritis. So we will mainly cover three aspects of it. First one is how osteoarthritis occurs, that is pathophysiology, of course. Second one is how to diagnose the patient with osteoarthritis. And the third one is physiotherapy management for the osteoarthritis. So, ma'am, my first question I would like to begin with is that since our literature has stated that pathophysiology of osteoarthritis is idiopathic or it is not studied uh, thoroughly. So
Hmm.
still, I would like to encourage you to think upon that on the pathophysiology of osteoarthritis and how it is taking place in an individual.
Okay. So basically, if we talk about the pathophysiology of this disease, so as you said that the literature states that it is idiopathic, right? And if we go towards the literature that has been done in the 1990 or before that, so it was basically telling that osteoarthritis is just a disease or a disorder that is occurring because of the mechanical factors, right? That there is a biomechanical changes in the body, and because of that it is occurring. But the recent advances or the recent literature which is already present on many of the platforms, and the recent articles, like if we go through the articles that are of the last 5 years, then they are stating few of the factors. The one component for the pathophysiology will be that osteoarthritis is considered as an inflammatory disease, right? If you go into the deep of this disease, so basically what we have listened is that osteoarthritis is a wear and tear disease and the cartilage is being rubbed. But if we think on that, the cartilage is not having any kind of pain receptors present, right? So if the cartilage is only going under the wear and tear component, then how come the patient on the very primary OA stage, right? OA stage 1 only is feeling pain. Okay, so this is because this is stating that, okay, not only the cartilage, but there are other factors wherein the surrounding musculature is being affected, or the synovial membrane that is secreting the synovial fluid, that is also affected, and then eventually synovitis is also occurring. So one pathophysiology behind this is inflammation. Second, if you correlate with it, and that is a little new to the system, and especially to the physios, because I have never done such discussion with any of the physios related to that, and that is the microorganisms present in your gut. So basically the microorganisms present in your digestive system. Okay, so now this is getting a correlation of metabolic factor along with the inflammation with the pathophysiology. So, what is the role of the organisms present in your digestive system is that they absorb nutrients and they carry the nutrients, and like whatever food you are eating, and that eventually is being absorbed and the nutrients are then distributed into the body. But when these microorganisms are not actually properly working, this may also lead to the metabolic changes at the level of joint, and eventually it will cause the osteoarthritis. So these are the two basic new additions to the pathophysiology of the osteoarthritis. Other than which we already know that the biomechanical factors and obesity and wear and tear theory and etc.
Okay, so first one you have told that biomechanical changes. Second one is wear and tear of cartilage, and
Hmm.
then further synovial fluid and
Fluid, yes.
synovium is getting damage and osteoarthritis taking place. And the third one, you metabolic
We
changes,
talked about, yes, metabolic. That is,
microorganism.
so that basically the terminology which you will find in the literal literature is gut microbes or gut microbiome. So that is a terminology used for the microorganisms present in the digestive system. But still the research is going on into this aspect. And the fifth one which we discussed was inflammation.
Okay, thank you. So moving to my next question, when patient come to us with osteoarthritis, so what are the things that we have to look for and how to diagnose the patient with osteoarthritis?
Okay, so the first and foremost thing which you should take into consideration is history of the patient. Listen to the history of the patient. Even if we talk about knee osteoarthritis or if it is any case, then the history is the most important part. You will be able to do the differential diagnosis on the basis of history. So in history also, the one of the important thing is that whether your patient is giving you the traumatic history or non-traumatic history. Right now, as we are talking about only primary osteoarthritis that is being occurred or that is differentiated from secondary OA in terms of trauma, right?
Yeah.
Secondary OA will be basically that if any trauma has occurred and after that trauma, the patient has the symptoms of osteoarthritis. Okay.
Yes.
So yes, if I talk about the diagnosis related to primary OA, so first question which you ask is whether they have any history of trauma or not. Okay. The next thing will be in your demographic details, the age factor will be very important. So, for example, if you have a patient or young patient coming to you and of 17 or 18 years, then you cannot put OA as one of the differential diagnoses. So again, that will be important.
I can think upon a secondary type of.
Yes, you can think of the secondary type, but again, you will differentiate it into the history part. Yeah. Because in history, you are obviously going to ask that whether you have suffered any trauma or not. So if the patient is telling that yes, there is some kind of trauma, then it may be related to some other structural injury as well.
Ligament or anything like that.
Yes. Then in your demographic details itself, there is component which we always take, that is gender. So gender also plays a major role. In literature, it is observed that knee osteoarthritis is more prevalent in females rather than males. Now, again, why so or what the explanation goes behind this is that in females also there is a specific age that is postmenopausal. So after postmenopausal is that after the menopausal age, that will be falling after 55 or 50 years of age, wherein the menstruation cycle stops. So in that, the level of estrogen decreases and eventually it is also correlated with the pathophysiology of OA. So these will be the three things. Then when you come to other components of the assessment, that how you need to diagnose. So as the observation part comes. So if we only talk about stage 1 or stage 2 OA, you might not feel or you might not be able to observe any postural changes specifically in stage 1 OA. But when we talk about stage 3 OA or the other stage than that, then there might be genu varum present. Okay, so again, that will be a component that might take you to that, okay, this patient is having a genu varum deformity, so this might be related to it. Then coming to the palpation part, patient might give you a specific tender spots, specifically on the medial side of tibiofemoral joint or over the margin of the patella. Because knee osteoarthritis will be into both the joints. Either it can be tibiofemoral or it can be patellofemoral. So again, how your patient is giving you the history that, okay, I have pain. And then when you go for the palpation component and when you check, then you get an idea that, okay, the specific, there is a tender point at medial tibiofemoral joint, then this might be OA. Or if the patellar margin is affected, then again, we need to take into consideration. One assessment aspect which can be taken for the examination, one is that you can check ROM because in many of the patients, there will be a component of stiffness present. or your patient may give the complaint of joint stiffness in the history part, wherein they may tell you that whenever I am sitting for more than a few minutes, like for example, I'm sitting for 30 to 45 minutes, and then as soon as I get up, I am able to feel the pain. The weight bearing is giving me pain. But actually, that weight bearing is not the issue. The issue is the joint stiffness, that the inactivity of those 30-45 minutes has caused the joint stiffness, right? So again, this could be component of history. And another thing which you can do is for differentiating your tibiofemoral OA and patellofemoral OA, you can just simply glide the patella, and if your patient is giving you the positive sign that yes, it is painful, or you can do the compression test over the patella, and that if that test is positive, then again that might be into taking into the osteoarthritis. And lastly, if investigation is being required, like you are not able to rule it out or because of all of these things, then you may go only for an X-ray. X-ray is more than enough for diagnosing the osteoarthritis. But if you take a thorough history, you do a thorough examination, keeping in mind all these components, then you will be able to diagnose OA very easily.
Can you tell me that how can I come to know that my patient is having patellofemoral osteoarthritis or tibiofemoral osteoarthritis?
Okay, so first and foremost component will be the area of pain. So when you are palpating the tenderness, for the tibiofemoral OA, the patient will be giving you the pain area over the medial tibiofemoral joint. Okay, and when you are talking about the patellofemoral OA, the patient might complain you that my pain is near the patellar margin, the whole patellar margin. Okay. Another positive thing which you might get for patellofemoral OA will be that when you are just taking patella into the grip of your fingers, and when you are moving the patella, you will be able to, your patient may give you the sign that yes, it is paining, because the bony surfaces over there, there might be osteophyte formation also. Okay. Third thing is wherein you can just, as I mentioned, that you can just ask your patient to lie down, and what you can do is you can have this grip and you can press with your hand over the patella. So again, when you are pressing the knee joint specifically over the patella, so patient may give you again the positive sign if it will be a patellofemoral OA. And the last component could be that you ask your patient to do step up and step down. So when your patient is again giving the sign of positivity, then on the basis of this, you will be able to differentiate. And there are many cases wherein both the joints are involved. Tibiofemoral is also involved and patellofemoral is also involved. So in such cases, you will get positive signs in all the aspects which I have explained.
Oh, man, is it possible to have osteoarthritis in both joint, tibiofemoral as well as patellofemoral?
Yes, it is possible that many of the patients have complaints in both the joints, and then we are supposed to treat it accordingly.
Okay. So, after diagnosing the patient with osteoarthritis, which are the exercise we can give to them so that we can delay the progression of osteoarthritis from stage 1 to stage 2 or stage 2 to stage 3?
Okay. There are many factors coming into the management of osteoarthritis, but as you have asked me only about the exercises, I'll be focusing more on that. When you talk about the exercises specifically for OA, everybody should keep that in mind, that your quadricep is the knee stabilizer. Whenever you would have learned the anatomy, the quadricep muscle is basically known as knee stabilizer. So one of the very important muscle that needs to be focused is quadricep muscle. So you can go for the exercises, strengthening exercise of quadricep. Another thing which there is one muscle that is not taken into consideration while treating osteoarthritis, that is gluteus medius. And why your gluteus medius is important? So first of all, your gluteus medius is one of the main abductors of your hip. So you would have observed that whenever there are patients of knee osteoarthritis, what is their gait pattern? That will be mostly waddling, right? So they walk like, for example, my hands are two people. So how they walk is they walk in this way, right? They have the tendency of not doing that heel strike, foot flat, and the swing pace of the gait. So this pattern basically weakens your gluteus medius. So OA exercises are not only limited to that you are just focusing on the functional component. Yes, definitely we should focus on that, but gait pattern changes are also needed to be taken into consideration. So second we'll be focusing on gluteus medius strengthening, and one of the best exercise for that is clamshell exercise. Okay, so in clamshell, what you do is you just ask your patient to lie in side lying position, and they flex their knee up to 30 to 40 degrees, and then they are just opening their knees this way. So this is basically a clamshell exercise. Now we are only focusing on the strengthening component, then it might not work. We also need to focus on the stretching component. So stretching component may work in wherein you need to see whether hamstring is tight or not. And many of the people see this and they focus on the hamstring stretching, but none of the people focus on rectus femoris tightness and iliopsoas tightness. So these two muscles are again important for the stretching component. Now a question comes that rectus femoris is the part of quadriceps. So we are already doing the strengthening of quadriceps. So why we need to stretch that? But quadriceps, the name itself tells it is a four muscle, right? There are four muscles present in that quadriceps. So because of this, rectus femoris needs to be stretched. And in quadricep also one specific muscle which you might strengthen, again the literature is going on, like you will be finding many positive and many negative articles, and that is the strengthening of VMO, that is vastus medialis obliquus, right? So again many of the articles state that yes, there is a activation of VMO being done specifically in one specific exercise, and many of the articles are totally giving the negative feedback that no, VMO cannot be just activated individually, right? But as in a whole, quadriceps strengthening, gluteus medius strengthening, and your rectus femoris stretching and hamstring stretching are very important. And now literature says that all these strengthening exercises should be done more of land-based. That is more of the closed chain activity, rather than just asking your patient to lie down on the plinth and just asking them to do SLR. Because doing SLR is not going to help them in any of the functional activities. So basically our role should be always there that we ask our patient should improve in their functional activities. Okay. So the land-based activities and aquatic therapy again comes into a role very nicely, that wherein if you take aquatic therapy into consideration for the osteoarthritis treatment, then it is also giving amazing results.
Okay, you first discuss about vastus medialis strengthening, then gluteus medius strengthening for abduction.
Yes.
Then the third one you with clamshell exercise.
Clamshell, yes, that is for gluteus medius.
That is for gluteus, and stretching of hamstring muscle, rectus femoris, then iliopsoas as well. And then that should be land-based exercise.
Yes, more of the land-based exercises, because see, a very basic thing. Whenever a patient of O is coming to you, okay, so they come to you by walking, right? They are not coming on wheelchair, or they are not coming on a stretcher. Okay, so if a patient is able to walk, so it means that patient's knee is able to withstand the patient's body weight. Okay, so why not use patient's body weight itself for the strengthening rather than tying the sandbag differently in non-weight bearing exercise? Okay, so what you can what you can do is you can just simply ask your patient to go for squats. So squat is also a form of exercise that is increasing your strength of quadricep muscle. Okay, so you can go that way, land-based exercise, and then you can progress the exercises eventually, because there are many variations available for lower limb strength.
Okay. So after the TKR has been done to the patient with osteoarthritis, then which are the goals we should have and which exercise we have to give them?
Okay. When we talk about TKR, that is total knee replacement, and that usually is done at a stage wherein patient is not able to walk even, or not able to bear the weight even, or even to minimize the progression of the disease. What we can do is, the first and foremost thing will be the pre-operative physiotherapy. That is very important, that you educate your patient about what OA is and what will be the changes that will be coming after TKR. And as your question is basically after TKR, so I'll be focusing more on that. After TKR, you might focus on, first is the patient will be having one type of scar. So you need to focus whether the scar is healing, the stitches which your patient has, because on the immediate day the patient has been operated, there is a role of physiotherapy. So eventually, when you take into progression, you need to see that whether the scars are healing or not. The stitches are healing or not. Second is the stiffness component. Your patient might be in pain on the very first or 2, 3 days, and even for 1 week. Then your patient may say that I don't want to do exercise, or I don't want to move my knee. But that is not possible. So during that time, knee range of motion exercises are very important in order to prevent the contractures, right? So ROM exercises are again very important. Next is a very basic exercise, that is static quadricep exercise, that needs to be taken into account, because that will eventually help, or that is eventually doing the pumping action when you are doing static quadricep exercise, right? So you need not to ask your patient to hold that static quadricep. You can just ask your patient to do the static quads and then release, do it and then release. So your patient might feel a little mobility. Along with this, what other thing can be done is, on the non-weight bearing side, again, you can focus on the stretching component of your hamstring and calf muscles. Basic bed mobility and ankle to movement is again advised. And you can quickly focus more on the functional aspect of taking your patient into weight bearing position, right? Wherein you are just asking your patient to have a walk. Patient can walk on the immediate day and on the next day as well. You can take your patient with utmost care, and patient can bear the weight. So you take them for walk. And again, I'll come into the functional component or the land-based activities. So you can ask your patient to go for stair climbing, stair ascending and descending. And here also there will be a role of hip abductor muscles. And here also you need to focus that your patient's gait pattern is proper, because of the pain component, what basically your patient will be doing, and your patient would already had, your patient has the waddling gait. So patient after TKR also will be focusing on that component only, that okay, I'll walk like this only. So your patient after TKR also is walking like this. But right now patient has undergone TKR. So okay, it is because of that pain of stitches. But what after 1 month, when the stitches are completely healed? So what after that also, if your patient is walking in this way, so I would recommend that on the very first week, you focus on the gait pattern as well. And for that, you just need to educate your patient. You can apply the strategies of using mirror, or you can just draw foot patterns on the ground, and then you can ask your patient to put their foot on that specific patterns and then walk. So this much will be more than enough after TKR.
1 minute.
Yes.
So first we have to see that that stitches is healing or not, scar is healing or not. Then we have to focus on our own exercise to reduce the stiffness, and then we have to do static quadricep exercise, then stretching
Yes.
of hamstring, and what else you mentioned other than
We
after stretching?
After stretching, you can go for, as you talked about mobility exercise, then stretching and land-based activities, wherein you initiate walking and stair ascending and descending.
Hmm. So what about patient education of the patient with osteoarthritis?
Okay, this is very important, because osteoarthritis is not a disease wherein you can just put one hindrance in between and you can stop it. Okay, so it is a continuous progressive disease, and it is a degenerative disease. So you cannot do anything about the progression of that disease. But what you can do is you can educate the patient in terms of, you can explain the pathophysiology in a very layman term. You can explain the causes of the disease, again in a very layman language. Uh, and only asking your patient to do exercise will not do enough. Your patient needs to have lifestyle changes, because osteoarthritis is not only because of the aging. If any person is obese, then again that is a very um,
Weight
important
reduction is
factor.
required.
Yes, yes. So you need to educate your patient that why weight reduction is required. And for this, there are many videos available on YouTube or on any other platforms also, wherein you can easily show your patient that how actually the osteoarthritis is occurring. So you can go that way, wherein you are explaining the pathophysiology. Second is, it is important that you need to explain them that why exercise is important. Okay, because as soon as you are explaining the pathophysiology, in patient's mind the question comes that if pathophysiology is going to be working this way, and if we are not able to do anything at a bony level, so why am I doing the exercise? Right? So you need to explain that with exercise there is a balance created between muscles, and because of that balance being created, the strengthening component, the stretching component, the load which your knee joint is going to face in the upcoming years of your life, that will be taken more through the muscles rather than directly having that load on the articular surface of the specific knee joint. So likewise, you can explain them that component as well. What you can do is you can use technology in terms of education, wherein, or in terms of regular exercises, wherein you can ask your patient to set reminders for doing the exercise, or you can just give them videos that you are supposed to do this exercise. You yourself can have many awareness sessions in different societies, right? So that will be again a component of community, because as soon as there is no person who might not have got knee pain in one or the other way, so you can just go into the community and you can educate the community with awareness programs, or again using the technology by showing the videos. And eventually this is how you can educate them. Educating people at urban level might not be a difficulty, because they might get many of the terminologies which you will use in English. But when you are going into the rural community, patients have already adapted to that pain of osteoarthritis, because they are going into their farm and they say that they will typically give you a reason that if I sit at home and if I do rest, then who will earn for my home? Who will go to the farm and who will do the farming? So never say a no to the patient. Rather than give them alternative strategies that how you can cope up with this pain, or why every day you need to do the exercise. And then you can talk in their specific rural language, whether it is Gujarati, Hindi, or any other languages, and then you can educate.
Okay, ma'am, thank you. Other than this, I have one more question. Can I ask you?
Yes. Yes, yes, definitely.
So, I have a friend of mine whose mother has undergone PKR surgery in both her knee joint just 2 weeks ago. And her surgeon has suggested that you are not supposed to start any physiotherapy treatment until I don't remove your sutures. She is
Okay.
allowed to walk. She is allowed to do her houseworks and other ADL activities. But surgeon has suggested that physiotherapy treatment after suture removal. So, what's your opinion on this? Can we start physiotherapy treatment from the day one of TKR surgery?
Yes,
Or
definitely. We can start it, as I already mentioned about the after TKR protocol. So you can actually we have a very big role in function making your patient functional, making the patient functional after TKR. As you are saying that your patient is already doing ADL activities, the patient is allowed to walk. How come our role comes in there is that one role which we will play is that is we will be educating the patient. Okay. related to that what actually has been done at a joint level and why exercise is important, why basic ROM exercise is important, or why gentle calf stretching is important. Okay. Second thing, your patient is right now allowed to walk. So who is observing the pattern? Nobody, right? Patient is walking in the pattern in whichever they are feeling comfortable. So right now patient might be in pain, so it may be taking the gait pattern into wrong context. So again, we have a role wherein you are educating the patient that, okay, this is the gait pattern which you need to follow. Next thing, the more delay you do into the muscle strengthening, the more work you and your patient will have to do. So right now, the patient is only walking and doing the ADL activities. There is no specific strengthening component being added to any of the musculature. So eventually, this may affect the prognosis. So, and in such cases, what can be done is there can be a healthy conversation between a physiotherapist and between orthopedic surgeon, wherein the components which will be included in the first 2 weeks or 1 week of the physiotherapy, that can be discussed and then it can be sorted it out.
Okay. So, okay, ma'am, that was it for today. And if you want to share anything else other than this, you can share.
No, I just want to share that I am very happy being here and seeing you at this place and with so much of good confidence and so much of questions which you have in your mind. I definitely can say that there will be many such questions in the audience as well who will be watching this video, and they might get fruitful things out of this.
Okay, ma'am. It was my great pleasure to have you on my platform, and I am so glad to for this conversation. And you gave your personal time and effort for this conversation. So I am so thankful for that. Thank you very
My
much.
pleasure. My pleasure.
Thank you. Thank you. Okay, we are ending this move, right?
Yeah.
Bye.